active working sheath. So you can push from it, you can pull ACTs from it, you can push blood through it. But the interesting thing is the technology that's built into the sheath. All right, the technology is where the Seranus is. There's a 12-hour battery in there, and there's a wire from the 12-hour battery into the sheath that sends electrical activity that creates an electrical field. Now those outside sensors, that's what's creating that electrical field. The inside sensors are what's detecting a change in that bioimpedance. Now, if you can think of a groin with an impella that's been closed with a pre-close, and now there's a leak in it, and so now you're starting a hematoma. What this does is it detects a change in the bioimpedance, meaning there's going to be a electrical change in the electrical field. Okay, so this will go on. So I'm going to turn the device on. All right, and this is, you'll have to do this one. This one. Okay. So when we turn the device on, it's already going to be on when you see this. All right. That green light right here, okay, in the cath lab, it's going to turn a solid green. And what that means is these two inside sensors are getting the baseline bioimpedance of that patient. So your bioimpedance would be different than my bioimpedance baseline, okay? So if there is a change, these are measuring, the inside sensors are measuring a change in the electrical activity. So if there is electrical activity going through the tissue and then there is a bleed, there will be a change in the bioimpedance, which means it's dropping because there's fluid in there. All right, you're going to get an alarm around it's around a 50 cc bleed. You cannot even detect that. You can't feel it. It's around that bleed, that size bleed, and that's a first alarm. The second alarm is around 100 cc's. That's a little harder. You might be able to see that. But if you can catch that bleed from the moment it happens with pressure, we won't get to a second bleed. So if it does go to a third alarm, the third alarm means you've missed the boat, and you need to call the physician. We recommend that you call the physician on the second bleed, because if you didn't catch it here, it's progressing. So if it gets to a third alarm, you've missed the boat, but this won't shut up, so you do have to silence it. Okay, so really it's not about the physician's technique, it's really about what's going on with the patient, all right? Does he have renal disease? Does he have liver disease? Has he had radiation, all right? Is he anemic? Has the physician done a CTO or super high risk? Next slide. Or has this patient had a high stick? You guys know if there's a high stick, and they do close it, but if there is a hematoma at a high stick, you can't stop that. This can detect a high stick bleed, which I love, okay, because it's 20 centimeters long. Next slide. Okay. There are lots of clinical applications to this. You can use it on the TAVRs, on the EVARs, on the Impella cases, EP procedures. Anybody that's obese, you can't see a bleed. The little old ladies that haven't ever exercised in their life, they bleed a lot. Anybody with tortuous vessels, if they've had a hard time, we call it a hostile groin, those patients probably need an Impella. Okay, so we're really trying to stop this current problem of the retroperitoneal bleeds, or any bleeds that the patient doesn't remember the great care that they got in the ICU. They don't remember the great thing that they did in the cath lab. They remember this hematoma that now they've had blood, now that they've had, they might even have to do a cut down on this. We're trying to prevent all of this. All right, so how this does, this next slide is really talking about how the change in bioimpedance and the bleeds affect these sensors. Next slide. Okay, so this was the slide that I really like, because bioimpedance, I'm like, what's bioimpedance? But what it really does is these outside sensors create an electrical field. It's like two footballs on either side, and it's the change in that area of the bioimpedance. All right, so the national averages of bleeds, and I have St. Luke's national averages, but I have St. Luke's averages. but these are the national averages. 1 out of 4 Impellas bleed, and that's just a fact. Intra-aortic balloon pumps, almost 1 out of 3 bleed. All right, you guys know, you guys don't get the ECMO patients, but those guys bleed a lot. Okay. Next slide. So there's a lot of studies on what bleeding is and how much bleed there is. I know that they're using a lot of new techniques, the ultrasound in the cath lab, all these other techniques, but there still is a bleeding problem. So this device will help with the bleeding problem. Any questions?
None so far.
Good.